You know what? I did all that wrong. Hi, this is Julie. I forgot to press start broadcast, so you get to hear this again if that went through. Thank you for joining us, the international docs, the local docs, lunch hour docs, morning, wherever you're fitting us in. Please check the handouts to get those downloaded. And this time we asked several references I know everybody would want, so I made the handouts. If you have questions today, please put questions in the question panel. I'll bring those up as appropriate. We are doing this in 2 sections. He will cover some slides at the beginning and then demonstrate what all that research comes to when you go into the room with your patients. So without further ado, I'm going to turn this over to Dr. Cox, lover of all things spinal, spine related, and go right ahead, Dad.
Well, thank you for studying with me today. At the outset, I consider what we're going to discuss today a major part of the future of chiropractic medicine. To begin with, this patient case I received this week from a certified Cox practitioner named Kim Lombardi in Georgia. And I thought I would just share with you this case. If you look, here is an L4, L5, large disc herniation. So we're to the point in chiropractic that we want to know what is happening inside of the spine when we do distraction manipulation of our type and correlate that with the clinical outcome of the patient. Here we see a 300-pound, 350-pound, 6-foot man with some comorbidities who has low back pain, radiation into both legs. He's tried other things, drugs, other chiropractic, epidural injections, currently taking oxycodone, 4 tablets per day. He undergoes treatment by Dr. Lombardi, who is, I know personally, a superb physician in his ability as a spine manipulator. He treats this patient, and what is the clinical outcome? Well, note that the VAS drops from an 8 of 10 to a 1 of 10 with an infrequent episode of increased pain to a 5. His disability index, 34%, which is certainly a big drop for this patient from 58. And most importantly, you can see that his current use of opioids has dropped to 1 oxycodone per day. Is this a good clinical relief? Absolutely it is, because minimal clinical improvement today is what? 30%. You give a patient 30% improvement, you've done a good piece of doctoring. If one doesn't believe that, here's a paper I just received this morning from Spine Journal, February 1. You will not have gotten this one yet, but it's volume 46, number 3. And it's pointing out about real-time ultrasound imaging of the nerves within the psoas muscle during surgery. I mentioned this to you for 2 reasons. What is minimal clinical improvement? It's 30%, some say now 20%, and even some 10% is good clinical outcome. But most importantly in this paper is the use of ultrasound in studying nerve compression and results in spine surgery. As we proceed, the question that evolves is, and we will be addressing today and into the future, is what is the force of distraction manipulation needed to achieve clinical improvement? And how much is that force? Well, what does the literature say? Well, if we look here at Guo's paper that came out last year in Spine Journal in September, I'd like you to note this paper. Degenerated discs, and note carefully what it says. Degenerated discs exhibit greater reconstruction after low tension traction. It is clear that the intervertebral disc mechanical microenvironment meaning the interstices of the nucleus pulposus, the annulus, the tears, and the rents, depend to a greater extent on low tension traction than high tension traction. To me, that raises the question, what is high and low and optimum distraction force? Here's the paper that you've seen us discuss in Didactics by Isser Horobeti et al. And they published this in JMPT in 2016. The conclusion of this was that you use 10% of a patient's body weight versus 50% of their body weight as a distraction force, which gave the best clinical outcome in treating an acute lumbar sciatica due to disc herniation. The outcome was what? In the long term, patients with acute lumbar sciatica secondary to a disc herniation who received 2 weeks of lumbar traction reported reduced radicular pain and functional impairment. And they found that the initial level of medication was dropped, but during the 2-week follow-up, it was found that the long-term outcome and relief of disc herniation-induced sciatica was best at 10% of body weight compared to 50%. Now, I offer to you that some of you are using pretty high traction forces. We're going to look at that today, and what will the future hold for our studies? Here's Alexander, and these studies were done at Palmer and published in ACC conference proceedings in 2016. This showed that the forces delivered by a chiropractor using Cox distraction, lateral flexion, and circumduction on 12 patients showed that the load of distraction was almost 74 newtons, and with an automated distraction, 136 newtons. So we know the difference between manual and automated distraction exists, and we must take that into account when we are treating patients, because here is a comparison of forces of manual versus automated. Here you can see when you're doing it manually that the newtons when flexion were about 56. When you do it automated, about 74. Okay, pounds 12.6 to 16.5. Distraction with automated distraction went from 43 to 136. So we see that there is quite a difference between a manual and an automated distraction force, telling us that we must be tolerance testing the patient. We must be carefully increasing distraction forces as patient relief is attained. I'd like to introduce you to the work of Gay et al. At Mayo Clinic. Ralph Gay is a DCMD certified in this work. They published this in Spine Journal on stress in the lumbar intervertebral disc during distraction. They found that they took 4 lumbar segments, removed them, and put them under 90 pounds of distraction. They referenced Dr. Ram Godavalli, the PhD who heads our research, and myself were referenced in their paper. They also found that 366 pounds or 500 newtons, 111 pounds of distraction resulted in decreased intradiscal pressure. Posterior and anterior vertical stress were significantly reduced. This is the goal of distraction. Drop intradiscal pressure, increase foraminal area, increase disc space, and then Gay went on to state the following. Axial distraction without flexion or extension decreased nuclear pressure 99%. Yes, if you added flexion, it was 73, and with extension was 65. Now, what I'm suggesting to you as we move to future studies is that we're going to be using a lot of long y-axis distraction, because according to Gay's study, it gives us the greatest decrease in intradiscal pressure. Gay went on to say that you must realize that we in our study at Loyola Medical School and Heinz VA Hospital, we were distracting whole cadaver spines, unbound, non-rigored. They were removing a spine and applying distraction. So we isolate ours to a single segment where they were doing what? A column of 4 or more vertebrae. This paper came out in 2016 in the Journal of Manual Manipulative Therapy, the manual therapy spinal mobilization. And I use that term with you with this caveat. Certainly, there's a huge difference between treating spinal stenosis, regardless of the etiology, in someone 30 versus 60. Meaning that the younger person, you and I can cavitate. They have nitrogen gas. As they age, for me, and for some of you, I'm sure, when you attempt to cavitate, there is no nitrogen gas, there is no cavitation, but there is pain. Thus, we shift from young with viable high velocity, with age demanding a less strenuous manipulation, bringing about mobilization. And how effective is it? Well, this paper shows manual therapy, mobilization is preferable to conventional physical therapy to reduce pain intensity and disability in chronic low back pain associated with disc degeneration. Can I ask you a question? Is spinal stenosis becoming a bigger part of your practice? Are you seeing degenerative disc disease, degenerative scoliosis, Bortolotti syndrome, adjacent segment disease, post-surgical continued pain patients? Do you high velocity these people? I think not. We offer you this study for your erudite consideration. This paper was published back in 2017 International Journal of Spine Surgery. Spinal stenosis, the most common indicator for spine surgery over age 65. By 2025, 59% of people over 65 will have spinal stenosis. This says to me that our profession has no choice but to study the anatomy, the physiology, the pathology to develop the best non-surgical treatment for spinal stenosis, keeping in mind the work of Adagwa and the AMA itself. Now, what percent of these people go to surgery? 1%. That means you and I are responsible for well over 95% of these non-surgical backs. Here's a study done by Gudavalli and people from Loyola Med School on the intradiscal pressure changes in manual distraction, done at Palmer, Heinz VA Hospital, my clinic, George Yoakum's clinic, Ralph Cruz's clinic, Loyola Med School. And it led to what we're going to discuss today. Where are we, at least from where I sit, for the future? Well, we are going to be utilizing a correlation of the degree of force and the clinical results in treating various conditions of the low back. So where are we in this study today? What does this ultrasound study mean? Well, this study was done at Logan University of Chiropractic, headed by Norman Kettner. And just to share with you, this is ultrasound. This is what we will be using in the future to study spine movement as you and I apply distraction, spinal manipulation of our flavor of manipulation to the human spine. Here's a pre-flexion distraction spinal manipulation. If you'll look, for example, here at L12, the interspinous space is 0.69 centimeters. At 2-3, 0.8 centimeters, 3.7 centimeters. What happens when you and I apply this Cox distraction manipulation? Why do we do it? It's to reduce stenosis before we apply physiological loads of range of motion to that spine. Via V, if we are looking here at L23, 0.8 centimeters, and we apply distraction manipulation at 1 minute of distraction, you see that that 0.8 went to 1.17 centimeters. All of them increased. This one that was 0.69 increases to 1.10. For me, and I don't know how you feel, my colleague, I thought that was exceptional amount of distraction. Now, the next question is, how much force do you and I apply to a spine to elicit a given interspinous space increase? And then what are the clinical outcomes with various forces applied? Do you sense this? So then when we stop the distraction, 1 minute post-distraction, you see that the 1.10 reduces to 0.96 1 minute later, but we still maintain 3 millimeters, 2 millimeters, and 1 millimeter at the L3-4 of increase in the interspinous spacing. This was a movement with ultrasound of the changes to share with you what we will be doing in the future as we purchase ultrasound and begin these studies at the Kaiser University College of Chiropractic Medicine. Here is a study in neutral. The distance from L1 to L5 is 13.24 centimeters neutral. If we add flexion to that spine, they increase to 17.51 centimeters. And look how beautifully we can measure interspinous spaces. We've also done this at National University of Health Sciences. With the mathematics, it is my contention that we can measure interspinous, intervertebral disc space height, and foraminal area from these measurements. Time will tell. Here on extension, you'll note that this length from 1 to 5 decreases from 17.51 to 9.75. So when we look at this paper that has just come out in December of 2020 in Biomedical Research International about the spinous process inclination, I just got this paper. It talks about the fact that in spinal stenosis, the caudal orientation of the spinous processes is significantly associated with degenerative lumbar spine stenosis, showing that stenosis patients manifest a significantly greater inclination of the spinous process, something that we must include in our futuristic research. So when we move into this to document these force changes and the biomechanical changes that take place within the spine, we have IRB approval being sought at Kaiser University to measure these forces, the changes in the biomechanics of the lumbar spine, and ultimately what? The clinical outcomes of these various forces. So at this time, I would like to take you to the instrument, share with you manual automated distraction, the difference between low and high force, and see what this will hold in our future research. So let's go to the instrument.
I have 2 questions on what you just covered. Are these MSK ultrasound, musculoskeletal?
Yes, of course.
Okay. And can you define what spinous inclination means?
Yeah, the paper I just cited to you. You picked up on that, huh? I just got this paper, and it's talking about the inclination, instead of being more of a posterior posture, is inclining more caudally. Probably, and they don't even intimate what it means. The finding is there. It's up to you and I to determine what does an increased inclination, how does it cause or feature into spinal stenosis? They didn't answer it. It's the first time I've heard it. Hopefully some of you in the audience will be studying and writing a paper on this as well.
Okay.
I'm ready to go to the instrument.
Okay, while he transitions and gets his patient set, he was a little excited there, so So we went a little long on that segment, but technology is great, but it makes me nervous. Okay, so you should be seeing Dr. Cox at the table and the table that will show you the forces while he's treating. You're on.
So we've discussed low versus high force. What does that mean to me and to others in the research of our technique? Well, it means what is the difference between 2 pounds and 6 to 8 pounds of distraction force? We begin at low force. Can I ask you a question? Have you ever noticed that sometimes the more gentle you treat a patient, the better the clinical outcome? I've seen that so many times. Let me share with you the difference between low and high force as measured with the force instrument. The new force instrument will allow future research to show you and I the best force to use for a specific condition. Let me just share this with you. I have already begun to prepare what some people call cookbook, what I call it essential protocols, for the treatment of this instrument for specific conditions. This is one called the Cox Distraction Spine Manipulation Protocol for Degenerative Scoliosis. Forces, distractive force, expected clinical outcomes from following this protocol. If any of you are interested in seeing this, I'm sure ready to share it with you. But I think that we are ready with the use of the wonderful force instrument developed with Haven Innovations engineers to determine specific treatment and force for treating individual problems of the low back, degeneration of the disc, Bertolotti syndrome, true and pseudo spondylolisthesis, degenerative scoliosis, synovial cyst, etc. That's the future. Let me share with you a low force performed manually with the instrument. Tolerance test first, contact L5 spinous process, and if you'll look under the y-axis force in pounds, I'd like you to note the taut point. Now, as I apply distraction, you'll note that the light blue line is the force of my hand, the dark blue line is the distraction force by utilizing the caudal instrument. Starting all over again from neutral, I make my contact on the spinous above the disc and triple joint complex to distract. I bring it to the taut point. We call this the barrier of elastic resistance. We've taken all of the slack out of the tissue. Now I apply, you'll note I'm here at 3 pounds of distraction. This would be low force distraction. 2-3 pounds. This gently applied at L5S1. This is low force. This is where we begin with treating acute disc herniations and chronic low back pain. It is safe, it's tolerance tested. We then can increase this force, and for me in a low back, please note, I can get good results at 2-3 pounds of distraction, which is what you're seeing here. And iatrogenesis nil. But if you start out too heavy, then you can have patients react negatively. So we begin at low, and now watch, I'm going to double this force. I'm going to go from 2 to 4 pounds. There's 4 pounds. And you can see the increase on the sine wave as I apply about 4 pounds. Now my colleague, this is where I treat maximally myself. Now just watch if I were to take and double that and go to 8 pounds. For example, 8 pounds. Do you see the increase in the sine wave? In my opinion, I don't need that. I know you and I know what's going on. We're increasing disc height, dropping intradiscal pressure, increasing physiological range of motion, and increasing foraminal area by 28%. The difference, therefore, between low and high force. Now, note what happens as I move up. Let's say I go up to the L2 level. First is taut point. I distract, and you see I have to use more force as I move up because I'm now distracting 4 segments instead of 1. But still, you'll note that I'm still not going over 5 to 6 pounds of force. You can see the graph, the beautiful, smooth, rhythmic oscillation of mobilization, distraction, manipulation. Now note, if I move to automated distraction, as we showed on the graph at the study done at Palmer, you can see the increase in the force. Just watch as I hold L5, taut point, and apply automated distraction. Note that those forces are going up there 12, 13 pounds. Therefore, when I start with acute backs, with or without sciatic radiculopathy, I start here. Low distraction force, 1 to 2 pounds. Those of you who have done this technique, and I'm quite aware of the talent in this audience today, you know that this gets positive results. When you start increasing the long y-axis, one wants to make sure of 2 things. Number 1, this patient is responding positively to manual care. And number 2, that you are tolerance testing very carefully as you apply this technique. Yes, I'm aware, as many of you are, that this patients say, "Oh, doctor, it feels good to stretch me." Yes, just it's a degree of stretch, the degree of force that we are applying, and when the future research will show the relief that we are giving, the clinical outcome with those forces. So if I move up to L2, for example, and I use long y-axis automated, note the movement. Here I'm going up to about 18 pounds of distraction. You'll see that I never exceed 25 pounds on a columnar distraction force. For example, if I'm distracting the entire lumbar spine, I'll set it for 25 pounds, which I'll show you in a moment. But you see the difference between high and low force? That's what I'm trying to bring across. And in the future with ultrasound, what we hope to see is the difference in interspinous space on different distraction forces and the clinical outcome of the patient's various spine conditions under those forces. Now, let me take you one step further. I lock the instrument, okay? And I'm going to use unattended long y-axis distraction. I'm going to set the depth of motion at about 2 inches. And I do that with the computer. Set it for 2 inches. And set it on automated and start the instrument. Now watch the force on the instrument. You'll see that with no contact on the spine, and I'm applying a generalized distraction, not specific segment distraction, you'll note that the forces are going at about 25 pounds. Okay? But I'm distracting a column of vertebrae. Patients with degenerative disc disease, back, and sclerotogenous pain, not dermatogenous, sclerotogenous pain like this is positive. We can apply tetanizing galvanic currents to the spine as we apply distraction. So I can measure the force, tolerance test the patient, and add hysteresis or detente to this by doing this. Now when I distract, I will hold this patient under a given distraction force. Okay. You'll note on the chart, can I go over and mark that?
Yeah, use the mouse.
I'll have to use the mouse.
Yeah.
I just
They
want them
can't see
to,
that.
huh?
Use the mouse.
I want you to see the distraction maintained in this patient. Can you see that?
I see it.
So I'm taunting here for 2 seconds. I'm holding them to increase what, and I'm not going to do it today, but next time I'll discuss Wong, Beati, Kuo, and Chung, okay, about what must happen in the spine to have a positive outcome with a chiropractic manipulation. This is what does it. I'm using the taunt. Now, I'm going to stop this, and I want to share with you one more thing. I've got this set at 25 pounds. I can set the distraction force at anything you want. For example, if you'll look at that table, you see I'm changing the force. I like to set it for 25 pounds. Okay? At 25 pounds, when I run this instrument, you can maintain that degree of pull, that force. That is optimum clinical outcome for that patient by setting the distraction to automated, and this will maintain that degree of distraction force even if the patient moves down. If they move, it will maintain 25 pounds. Even if I come down here and it just begins, once it hits 25 pounds, it returns to the top. So the instrument will maintain that force regardless of how the patient moves or they begin to relax. We will add distraction. We can even apply a thoracic restraint to a patient, and I can isolate my distraction force to a specific number of vertebral segments, anywhere from 1 to 10, by using a thoracic restraint. So what I wanted to share with you is the different forces that you and I can document now with this advanced research done with the engineers at Haven, and what the future holds for the verification and explanation and benefit of chiropractic spine manipulation. What about the cervical spine? Well, I'm going to stop this, and you'll also note I have the cuff on this patient. You can get the same result without the cuff, especially as patients age. The older stenotic degenerative spine likes less force. Younger people can tolerate more. So I release the distraction force. I am going to move to the cervical spine. And I'd like for you to note, my colleague, that treating the cervical spine is extremely important, especially in the time when we live in degenerative cervical myelopathy cases, which are increasing all the time. We said that by the year 2025, that 60% of people over 65 will have spinal stenosis. There's no way that you and I will escape having techniques to match the challenge of those cases. Let me allow me to show you how we treat cervical spine. Remember that when we do the cervical spine, we isolate basically on 2 segments: foramen magnum pump and C5. Foramen magnum pump force and C5 force are very low. We will start in a cervical spine at very low force. We will determine lordosis or kyphosis by the pressure downward or lifting of the cervical spine to return a more normal cervical lordosis to the spine. But when I begin with foramen magnum pump, basic occiput here, I'd like you to note the force I'm using. First of all, I move, as usual, to the taut point. Now you will find that in the neck, you got to go a little more cephalid distraction to reach the taut point, because I'm distracting the entire spine. So with my foramen magnum pump, this hand, this tiller bar moving in unison, there is the taut point. You can see the two blue lines, very level, very static. Now note 1 to 2 pounds of force. You can read it on your reading right under the y-axis force. That's the force that I begin in treating cervical problems, whether it be disc degeneration, disc herniation, spinal stenosis. And if we move to C5, it's the same thing. Arch here, spinous here, closed down like a vice grip on C5. And note, first of all, taut point, the distraction force, no more than 2 pounds. This is where I begin. Doctors, many of my people get well at this force. What do you think? As they respond, watch when I double that. I go from 2, you'll note the sine wave increasing. Julie, can you start that again?
Yes.
It does have a timer on this for you. Now note, when I'm going to double, going from 2, here would be 2 pounds of force, to 4. And you can see the increase in the sine wave. Again, low force, 2. High force, move to 4. And this is one individual segment. Now I can double that very carefully, and here's what that curve would look like. Again, low force, start at 2 pounds of force. Whether you're at the foramen magnum pump for full spine and cervical distraction, or isolated to a C3, C4, C5, C6 disc. Low force versus high force. I'd like you to watch one more thing in this application. I'm going to use this hand on the basic occiput, this hand to support it, and I'm going to apply long y-axis distraction. Now watch the force. This is good technique, but not in an acute neck or an acute disc herniation, only after the patient is showing good clinical response and tolerance to this. I like to end every adjustment with this, but you'll note the forces are greater. I'm going here from 1 to up to 16 pounds. Now, you can do this because we're applying a long y-axis distraction to several segments of the spine. You'll always remember that thoracic manipulation with this technique is 20 times slower than a high velocity. I'll end with this. You may be getting tired. I make a contact, no thrust. Just hold like high velocity, but let the instrument do the distraction. The yellow line on the middle is thoracic force. We can measure these forces. You can document them in your records. You can show that with patient relief that these forces can be increased. this meant with our future research in studying interspinous spacing, clinical outcomes, different forces to allow us to determine the optimum protocol for various conditions of the human spine. To me, this is an advancement of our profession that is necessary, valuable, and very exciting. Thank you for studying with me today.
Well, thank you. You just went over just a little, but it was fun, I could tell. I have a couple questions. Has there been any discussion of MSK ultrasound certification?
Yes,
Do this?
I haven't discussed it, but I know of people who have. Lee Hazen was a resident of mine. I trained. He's in Temecula, California. He's certified. Alicia Yoakum, I think Patrick Batiglia are certified musculoskeletal people at National under Bill Bogar's radiology residence program. They are doing this work, and we've done some of it there as well as at Logan. But the future is that we will be doing this. In fact, we're looking right now at the new GE ultrasound units that with the highest resolution to do these studies. I think if you saw what we did, that was pretty clear. And so we will be getting that ultrasound to do these correlative studies. So the answer to the question is yes.
Dr. Brinkman just followed up and said that Logan's postgrad is offering some sort of a certification.
Oh, good.
I'm not sure. Yeah, postgrad offered U.S. in the past. So there we go. And I got to follow up. What I meant was, is there discussion of a class through National Archives? Or no, not National Archives. We don't have anything on certification with ultrasound right now. We're just working to get the ultrasound.
Sure would like to have it.
Yeah,
I mean,
that would
you're
be
very futuristic, Doctor.
Yeah, this is exciting.
Yeah.
This is great.
But you know, an idea must be planted, grown before it's harvested.
Oh, we're having a hard enough time just trying to get the ultrasound units tested because of COVID, but that's a whole other story we won't go into right now.
Yes, COVID has held us back on our research
Slow on everything.
a lot.
Let's see. Let me see. I've got another question. Dr. Shore, you and I are going to have to talk offline. I know you're excited. He's over in England working on different courses being taught over there. But you're asking about tables getting into schools and all that. You know, that really does have to go through Haven. Haven's been an incredible support source for the technique and training and getting tables. And they do have, you know, you got to talk with them about schools and educational discounts and all. I know there's no way to accommodate everybody, but do talk with Haven, so I can get you in touch with them. Looks like you're connected in a lot of places, so we'll talk about that later offline. Got a few thank yous. If I missed a question, I'll follow up with that later. But let me finish up. He's going to do part 2 of this webinar on January 20th at 12:30. It will be a little shorter, I think, because you're just going to cover determinants and some things, but then again, he gets excited. If you want more information, we do have some online courses strictly on the forces that goes a little more detailed and in depth on that. We've got workshops, online credits. I've got a whole bunch of 160 courses online for CE credits. Hopefully we'll be doing live courses soon. Force Table, talk with Haven. They are an incredible support for doctors, education students, and everybody. And we look forward to seeing you next time. Get in touch with us. Email me if you have follow-up questions. We had a lot of interaction today with questions. We don't get this many.
Can I make one point?
Yes, go.
What you see here is not an accident. It's like John Ruskin said, quality is never an accident. It's a result of intelligent effort, and there must be the will to produce a superior thing. Among all of the mistakes I make as a chiropractor, clinician, and radiologist, once in a while we do something right. And one of those things has been the combination of working with Haven's engineers. And I want you to know I own no part of Haven Innovations, okay? I use their engineers and their brilliance to take our research work to make it available for you and myself as a clinician.
Well, there we go. That's the way to end it. This has been fun. I really enjoyed the questions. I'm so glad that you're taking advantage of the questions. It expands our reach and understanding for everybody. So we look forward to seeing you soon. Follow up with me by email if you have any more questions. And we look forward to seeing you on the 20th. Go back and treat your patients this afternoon.